All right. I think I'm still sharing. Yes, I am. All right. So good morning, everybody. Thanks for joining for this week's AMSSM Sports Ultrasound case series. Before I introduce our speaker, just one housekeeping point here. We're just about to actually pass, I think, the halfway mark with this section of faculty presenters, and Doug and I will start to compile a list of potential fellows for our next section, which will be all sports medicine fellow presenters, just like we did prior to this section. So we'll be sending some emails out after we compile a list. But if there's any core faculty out there that have some high level fellows that are interested in ultrasound and would be willing to present a case, feel free to shoot me an email. Just to put that on my radar. That's always helpful for us as we compile our list. So all right, so with that, so today we are fortunate to have Dr. Emily Dixon here. She's going to be given a case of a deep infrapatellar bursitis here. So Emily, she got her she went to medical school from Ohio University College of Osteopathic Medicine in 2007, and then followed by a family medicine residency out in Cincinnati, in 2010. She did her sports medicine fellowship at Beacon Orthopedics, and she's currently faculty with Tri-Health's primary care sports medicine fellowship out there. You may have heard us talking previously, but she's currently faculty with AMSSM fundamental ultrasound course the last 5 years, and her and Shane Shapiro will be co-directing the course this year. So we are fortunate to have her give us a talk, and with that, I will let Emily take it away.
All right, thanks, Ryan. I'm joining you all from beautiful, gloomy Cincinnati in my exam room 1 today. So hopefully we can see can you all see my screen there?
Not yet.
Okay, not yet? Okay,
not yet.
1 second. This is the issue I was having last night. Share screen. Share, there we go. Is that working? There we go.
That's good.
Okay, I did that last night, so sorry about that. Okay, so we're gonna go over a case series of deep infrapatellar bursitis. So I was fortunate enough to pick a fairly easy anterior knee scanning protocol with this. So the main objectives of this talk, we're going to review the scanning protocol, diagnostic ultrasound of the anterior knee, and then review ultrasound images of said protocol. I think this is one of the most important things that fellows need to learn very early on in their fellowship, because you're going to see a million knees and scan a million knees. So I think it's wise to kind of have this in your wheelhouse. We'll review pathology of anterior knee bursitis, and then go over the how I type up the ultrasound report. So when we talk about knee bursitis, the most common is going to be your suprapatellar, your prepatellar, and your infrapatellar bursitis. You will 100% see this in your practice or during fellowship year. It's very common. The big things with these is they can look a little bit different depending on what the type of pathology it is. So in this first picture over here, this is the patella. So this is a true prepatellar bursitis, and you can see this hypoechoic thickening of the bursa. And in this bursa, you've got this complex fluid in there. You also may see more of a hypoechoic signal, and this is kind of more of that infrapatellar bursa. So here's our patellar tendon coming down to the tibial tubercle, more of a simple type fluid. You can see here there's maybe a tiny little septation in that. And in this view with the patella, you can see these gas molecules. And the big thing is the gas shows this posterior acoustic shadowing. That's really important to identify if you see any flow or thickness to it, because that could be a sign of infection. About 30 to 40% of these prepatellar bursa and anterior bursitis can actually get infected. So we're going to go to our case now. So this is a 37-year-old white female who presents to clinic to me from referral from a colleague for a PRP consult for chronic pain due to Osgood-Schlatter disease. And I thought that was odd because she's 37. Why is she still having pain from Osgood-Schlatter? But she's an avid CrossFitter. She's been doing having more anterior knee pain and swelling at the tibial tubercle, mainly noticing it with decline lunges, squats, and deadlifts. With the swelling, she's taken ibuprofen. She's modified her workout a little bit just to unload the patella to see if that would help. She states she had Osgood-Schlatter disease as an adolescent, But now she's noticing that the bump on her shin is actually more prominent than it used to be. So this patient is actually a nurse practitioner within the hospital system I'm associated with, and she had actually researched PRP injections and was just curious if it would help. So she hit up one of my partners in the hospital, and he recommended that she come and see me. She was also scheduled to run a virtual half marathon in 2 months. So she wanted to know timing of PRP and injections and kind of exercise restrictions with them. So like any good orthopedic office, we get X-rays before the patient comes in. So this is her lateral view. Very obvious, she's got this pronounced tibial tubercle with the sequela of that Oshkosh-Slaughter's disease, but really otherwise fairly normal looking films. Maybe you can appreciate a little bit of soft tissue swelling in that anterior knee. On her exam though, she had noticeable prominence of that tibial tubercle with tenderness to palpation over the insertion of the patellar tendon there, but full strength with active extension, so no weakness of her extensor mechanism. I like to do dynamic testing on my patients, so I'll often have them stand on one of my stools in the exam room and do a single leg squat. And she had a little bit of valgus knee with that, but overall pretty strong with her hip abductors. Her ligaments were stable, so she had a negative Lockman's anterior posterior drawer, negative McMurray's, and she was stable in varus and valgus strain. So we're going to get to our protocol here. So the anterior knee scanning protocol, today we're going to really focus on the items in red here, including the patella and prepatellar bursa, the patellar tendon tibial tubercle. So we're kind of looking at that inferior knee, Hoffa's fat pad. But it's important to be able to know that you got to follow that distal quadricep muscle down, look at your quadricep tendon. Obviously, the suprapatellar recess of the knee joint is one of the most things that our fellows are going to be injecting, whether it's doing viscosupplementation injections, aspirations, and injections. And then being able to look at both the medial and the lateral retinaculum with the vastus medialis and vastus lateralis. MPFL is obviously a big area of pathology in sports medicine, and looking at our trochlear cartilage and meniscus. Optional is the infrapatellar branch of the saphenous nerve. When I teach my fellows, I tend to focus on the high yield things. And then towards the end of whenever we finish a joint, then we'll focus on the nerves and everything. And this is obviously on the updated curriculum that was just published this fall. So big shout out to my fellow Nate McKinney for having the excellent quad tone for these pictures. So when we talk about our scanning protocol, we're always going to talk about a short axis versus a long axis view with your probe, but that is not always going to follow a sagittal, coronal, and axial view that we talk about in MRIs and CAT scans. So the big thing with the long axis view is making sure you get that probe on the tip of the patella and kind of center over the quadricep tendon. And obviously make sure you're stabilizing the probe down onto the skin. In these pictures, I kind of have my hand held up just so you guys can see my probe position, but we talk about not walking the dog by its tail. So making sure you have those good points of contact on the skin. So the quadricep tendon here in this long axis view, we see our patella here, the quadricep tendon here. It should have kind of a trilaminar appearance. And because, again, we're looking at a 3D structure on a 2D image, you're going to get that little bit of an anisotropic signal as it comes into the patella. So my quadricep tendon is in plane here. Here I can kind of tilt the probe and do little heel toe maneuvers to get that in plane. And then you're going to see your hyperechoic femur. Here we're going to see our quadricep fat pad, and then you also have your prefemoral fat pad there. So in our short axis view, you're going to see the quadricep tendon as that fibrillar pattern coming straight at you. So often I'll tell fellows it's like looking down a hose. So we're looking at it in the length of it. And again, the hyperechoic femur here with the prefemoral fat pad. This layer here, right in between those two levels, is where we're going to do our procedures. So when you have a patient with an effusion, it's going to look like this. So patella's here. Here's our quadricep tendon with that fat pad and a big effusion above that prefemoral fat pad. And often you can milk that effusion to see the fluid. Pro tip is when you're going to do an aspiration, most of the time that's done in that short axis view, but with the needle in a long axis view, make sure if you have your probe on the tip of the patella and you rotate 90 degrees, you should be above this quadricep fat pad, which your patients will appreciate. It's not fun if they get an injection there. So when we look at the patellar tendon and the anterior joint recess, most patients, you can get that full length of the patellar tendon in one view with your linear probe. However, if you have a taller collegiate basketball player or someone who's really tall, you may have to slide kind of proximally and distally. So in this view, we've got our patella here, our tibiotubercle here. It's important to scan that patellar tendon all the way lateral to medial. Patellar tendons can range from 1.5 centimeters to 3 to 4 centimeters wide, depending on how the size of your patient. And the patellar tendon should be uniform. So we should see this nice fibrillar pattern. Most pathology on the patellar tendon is going to be found centrally and medially. So you're not going to see as much on those lateral fibers. And that's just typical for jumping athletes. Well, also on this view, we'll catch our femur with the hyaline cartilage signal, our Hoffa's fat pad here in the middle, and then you can often appreciate some cortical irregularity or changes on that tibial tubercle. When we're scanning this anterior joint recess, especially when you're looking for bursitis, it's really important to float a lot of ultrasound gel and watch your probe pressure. All the time, my fellows, when they come in, when we were first training them, you'll look and they're almost indenting the skin because they're pushing so hard with the probe. I think they just think if you push the probe harder, you can make the images better, but that's not always true. So it's really important in this, if we were going to look for a prepatellar bursitis or an infrapatellar, it'd be right in these tissue layers here. So if you're compressing those, if it's a very small bursa, it could completely occlude the picture for you. And in this view, my probe's going to be on the end of the patellar tendon and going down to the tibial tubercle. So I'll have this little demographic on all these slides to show my probe position. Okay, so when you could talk about the anterior knee, it's important to scan down into the medial and the lateral retinaculum. And I find this can be a little bit tricky because when you start, what I usually do is I follow the vastus medialis, the VMO, or the vastus lateralis. I'll start in kind of almost a short axis plane and then rotate my probe down as we're going and following that retinaculum. The retinaculum is typically a bilayer structure, and the capsule is actually adherent to that retinaculum deep. So the big thing with the retinaculum, both medially and laterally, is it's actually a stabilizer of the patella. So it works with the patellar tendon, the quadriceps, with extension, and it's a passive stabilizer of the knee. So when we're looking at the medial retinaculum, you're actually going to catch your vastus medialis come into that medial retinaculum, and deep to that, the deep fibers medially are actually fibers from your MPFL, which is more of a compact fibrillar structures. And I have a good picture of that in upcoming slides. But it's important to note that this VMO comes down more distal than the vastus lateralis. So your lateral retinaculum here is going to be a much longer structure, with the lateral femoral condyle coming down. So you're not going to have as low level muscle fibers coming down, but it's important just to see that all the way to the patella. So here's my vastus medialis, a little sin loop going through here where I'm following that VMO. You can see where I kind of rotate my probe and we're catching that medial retinaculum coming all the way down to the patella. In our patient, her medial retinaculum looked perfect. With the lateral retinaculum, it's important to realize that if a patient has had a previous lateral release, which was actually very commonly done for patellofemoral pain back in the 90s, you might have some disruption of those fibers. So often they release that lateral retinaculum from the patella to the level of the arthroscopic port. So I talked to my surgical partner and he said, yeah, we just go up as high as we can and just kind of release it from the inside out. So if you see disruption of the lateral retinaculum, it's important to ask that surgical history. Our next step is going to be evaluating the trochlear cartilage and the meniscus. So the trochlear cartilage is best viewed with the knee slightly flexed. And you're going to put your probe kind of just above the patella and the quadriceps tendon there in the short axis view, but your cartilage is going to be in a long axis view. So in our patient, you can see she's got a pronounced kind of lateral trochlea with a more shallow medial trochlea. You'll see that a lot for patients who have recurrent patellar dislocation subluxation. You might see a shallow lateral trochlea, but you'll see this nice hypoechoic hyaline cartilage signal transversely. And then in our patient on this video, as I scan through her hyaline cartilage, I'm actually picking up this kind of cortical irregularity here on the medial trochlea, which is consistent with probably some a little bit of arthritic changes. And you can kind of see I lose my hyaline cartilage signal there. So that's kind of important to note that she might have some patellofemoral chondromalacia going on there. And then when we're looking at the meniscus, you're going to put your probe more in this kind of long axis view. The meniscus should look at like this kind of hyperechoic triangle on the medial joint line. So here's our tibia, here's our distal femur. The big thing with that, the meniscus, is you can pick up pathology on the meniscus, although we all know an MRI is going to be better to fully visualize that. But you can see clefts in the meniscus. Sometimes you can see parameniscal cysts. If we want to look at the anterior horn of the meniscus, here I've actually caught the anterior bands of my MCL here, so I'm fairly far medial. But if you're going to look through the anterior horn, you're going to move the probe anteriorly, kind of in a coronal plane to almost like an oblique sagittal plane to visualize the anterior horn. If you see an extruded meniscus, which this patient doesn't, hers looks perfectly normal, you can actually reduce that joint, do a dynamic valgus strain and see if that meniscus reduces back in. In arthritic patients, you'll often see cortical irregularity of the tibia and the femur, and also very, very common place right here to see a parameniscal cyst that can run along the MCL, and you can see those, I've seen those come all the way anteriorly to the anterior joint line also. Okay. So our next scanning protocol step is going to be our medial patellofemoral ligament with a dynamic patellar apprehension. So when you're looking at the MPFL, again, those deep fibers of the medial retinaculum are going to be the MPFL, and it's going to be this thick, compact fibrillar structure that runs from the adductor tubercle of the femur over to the patella. So we'll see this thick fibrillar structure going for a patella here or femur here. The MPFL should be pretty stable in a patient who hasn't had trauma. So what I do is when we look at this video of the traction here, is I will actually take my probe, get the MPFL, and then I'll actually use my fingers kind of pull it towards me, or I'll use my other hand to put a lateral traction on the patella. You can do that medially also, but you should see that MPFL just become nice and taut. We shouldn't see any disruption. It's often pathologic in patients with recurrent subluxation or dislocation. Upwards of about 94% of people will tear their MPFL on their first dislocation. Again, the MPFL is a stabilizer of the patella, so it's strongest between 0 and 30 degrees of flexion. And then as you flex more, it's actually the trochlea that becomes the primary restraint to lateral migration of the patella. So if you have someone with a very shallow trochlea, it's easier for them to laterally displace that patella and tear their MPFL. Rupture typically happens at the femoral portion of the MPFL, very uncommon to have it off the patellar side. But also as that patella subluxar dislocates laterally, you can also see an osteochondral fracture. But again, sometimes that is only seen if you're looking for a loose body. Sometimes you have to get an MR for further visualization. Okay, our next step in our protocol is going to be the saphenous nerve and the infrapatellar branch. So our saphenous nerve kind of is a sensory only nerve. So there will be no motor function involved in a patient with a saphenous neuralgia, but it travels with the femoral vessels down this adductor canal. And then this infrapatellar branch is a really common area for people to have pathology. And the easiest way to identify this, how I do it always when I'm doing a saphenous block, is I have the patient lay in a lateral recumbent or kind of frog leg to leg out, because you kind of really have to get into the adductor canal. I change my settings to a nerve setting here so that that can be seen. So I can see the nerve a little bit easier. The probe is placed kind of along the adductor canal, and I'll follow that down and kind of find the nerve. But what I basically do is I find my adductors, my vastus medialis, and I find my sartorius. And your sartorius should be this almost kind of nice inverted triangle there. And this is actually, this little dot here is the infrapatellar branch of the saphenous nerve. And so it's important if you're doing any sort of procedures in this area to block above that branch, because if you block below it, it's only going to go down to their shin. It's not going to get that anterior medial knee pain. So in my video here on our patient, here's our sartorius muscle with our adductor mus. Again, I usually use my large vessels here as an identification status. And I always tell my fellows, if you're looking for a nerve, find your big blood vessels and then follow those fascial planes. The nerves are always going to follow that fascial plane. So if you look right here, you're going to see this hypercoic ball kind of go up, and that's actually the infrapatellar branch of the saphenous nerve. It's tiny, small nerve. So this does take a lot of practice. So it's something, but again, just follow that adductor canal, find your big femoral vessels, and then identify the nerve next to it. In pathology of this, which our patient's nerve was completely normal, in pathology of this, you might see a thickened hypoechoic nerve, and they'll actually lose that fascicular pattern, that honeycomb pattern we talk about. So the biggest thing too is with my patients that most of the time I'm blocking this in a patient who's had a total knee replacement. So when the surgeons do the total knee, they'll take that skin, they'll open it up, and it can really put traction on that nerve and cause a little bit of pain. So if you have a patient who's 9 months post-op from their knee replacement and is continuing to have capsular pain and pain along that medial joint, but the surgeon says their X-rays look great, their implants look great, they're nice and stable, you could always consider saphenous neuralgia. And this is the same place where I'll use a kind of sonopalpation. So I'll do a Tidell's over that region once I identify it, and I'll actually use my probe and put some pressure on it and see if that causes any of their pain. Okay, so we're gonna go, so that is the anterior knee scanning protocol, fairly simple. But we're gonna go back to our case. So again, a 37-year-old white female who presents to clinic from a colleague for the PRP consult with swelling at the tibial tubercle. So on her picture and her video here. So as I'm scanning her patellar tendon, I'm scanning it from lateral to medial. So her femur is here approximately. This is her tibial tubercle. So you can catch that she's got all this cortical irregularity of this tibial tubercle as I'm scanning laterally, and that's consistent with her Oshkosh-Schlatter. You'll also catch little hyperechoic flex right in this region. That might be a little calcific tendinosis also. But the thing that struck me is right here, I could see she's got this hypoechoic fluid deep to the patellar tendon, consistent with an infrapatellar bursitis. And then her Hoffa's fat pad itself looked great. Sometimes we will see ganglion cysts in there. You can see edema and so on and so forth. So I quickly said, okay, sounds like she's got a little bit of bursitis here. This could be the cause, and it's not her Oshkosh-Schlatter. So this is a short axis view of this deep infrapatellar bursitis. So this is that very tip of that tibial tubercle, and I'm catching a little bit of her patellar tendon here, but I have that a little bit off plane because I'm focusing on the bursa. And what I do is I actually take my 4th and 5th finger as I'm stabilizing that probe, and I'll milk that bursa towards me, because your linear probe is almost always going to be wider than the patellar tendon in the area I'm looking at. So I'll float a lot of gel and then take my fingers and kind of milk that bursa towards me. So right here, you can see where that fluid is kind of milked laterally. This is lateral, this would be medial. And then when I switched to the long axis view, this bursa actually measured out to 2.7 centimeters. So it was quite large. So this patient then underwent a ultrasound guided aspiration and injection of the bursa. So in this view, I have the patellar tendon in short axis of this compact fibrillar structure. And then my needle is in a long axis plane. So you can see the nice reverb. So we know we've got that needle perfectly in plane. The most important thing I can tell about this when you're aspirating or injected in a very small area, because you can see my probe here is going across the that deep tibial tubercle. That's really shallow, very easy to do a through and through and stick your needle all the way through that bursa and out the skin the other side. So with value averaging that most ultrasound machines do, it's really important to make sure you can see the tip of that needle and kind of move your needle laterally as that fluid aspirates so you don't go all the way through. It's very easy to catch this part of the needle and not find your needle tip. So just make sure you always know where your needle tip. I'm constantly harping on my fellows, where's your needle tip? Where's your needle tip? So, and this was post-aspiration. You can see full collapse of that bursa. I actually aspirated 5 milliliters of fluid out of her bursa, and then we did a sterile syringe transfer for corticosteroid injection. So my ultrasound report, when we look at this, I always put, what area I was doing, why we're doing that, and then what transducer I use. Depending on patient's body habitus, you may be switching your transducer back and forth. So just make sure you note that. So in my diagnostic part of my ultrasound, I basically said the patellar tendon is intact without neovessels or evidence of tendinosis. There is cortical irregularity of the tibial tubercle consistent with patient's history of Oshkosh-Schlatter disease. There's a 2.7 centimeter hypoechoic area of fluid deep to the patellar tendon consistent with a deep infrapatellar bursitis. This correlates with patient's pain on sonopalpation. Again, I cannot stress importance enough of highlighting pain with sonopalpation. A lot of times when we're scanning or we're doing diagnostics or we're doing didactics, we can get so caught up with what's going on the screen that we forget to look down at the patient, see where our probe is. And so really, really focus on the importance of palpation. And I always tell my fellows, if you're trying to figure out where the pathology is, palpate first, then put your probe on and do sonopalpation with that. There's no evidence of gas, synovitis, or hyperechoic signal within the bursa. The Hoffa's fat pad is intact. I did note that she had mild irregularity of the medial articular cartilage noted on the trochlear groove. This is not fully visualized, and MRI would be recommended for further evaluation if needed. And then on her procedure note, I basically wrote informed consent obtained and sterile prep performed, superficial anesthesia obtained using 3 milliliters of xylocaine. And I do my anesthesia using ultrasound guidance. So I'll actually put the probe on. You could technically do that blind if you wanted to, but I always like to know where I'm putting that anesthetic. And then under direct ultrasound guidance using the linear transducer, a 20 gauge needle was introduced into the infrapatellar bursa. Aspiration of 5 milliliters of clear yellow fluid was performed with collapse of the bursa seen on imaging. And then after sterile syringe transfer, 1 milliliters of 40 milligram deprimedrol was injected into the bursa. So I actually have my assistant use a hemostat and we kind of switch the syringe to do that sterile syringe transfer. Patient tolerated the procedure well, and post-procedure expectations were reviewed, including her exercise restrictions because she's very, very active. When I built this, because she was initially being seen as a diagnostic ultrasound for a consult, I built it as a 76881 and then a 76942 for my ultrasound needle guidance. If this is a known bursitis patient, you could build a 20611, but I think it's really important. Just talk to your billers and coders to make sure you understand how all those work. Of note, this patient had complete relief of her pain and returned to activity, and we never did PRP, but I've also seen her a few other times for other issues because CrossFit is always good for business. So I'm going to give you a couple bonus case reports here. We have a 13-year-old female softball player who had intermittent swelling and pain of the left knee for about a month, but her x-rays from her PCP showed this infrapatellar soft tissue swelling, but near full skeletal maturity. So on her exam, it was like when she came in, it was this noticeable swelling in the infrapatellar and prepatellar bursa and the lateral joint line. But she had her knee exam otherwise was normal. So this is a picture of this patient. So obviously I immediately thought, man, this is a huge infrapatellar bursa. Did she slide into base wrong? Was there some sort of trauma? Patient completely denied that. On a diagnostic ultrasound, this is our long axis view. So femoral condyle, tibial tubercle here. So you can see her patellar tendon's intact, but there's all this complex fluid. And then on a short axis fluid, I could see this large amount of synovial thickening noted and hyperechoic signal, and there were actually neovessels in it. So I put my Doppler on and immediately I said, this isn't normal. This is actually in her joint and in that deep infrapatellar bursa recess. So we ordered an MRI, and her MRI actually showed heterogeneous fluid collection and frond-like nodularity, and that was suspicious for a focal nodule synovitis or a pigmented villus nodule synovitis. So this patient actually underwent arthroscopic procedure and had a synovial biopsy that did show that she had the PVNS. And PVNS is a joint disease characterized by inflammation and overgrowth of the synovium, and it can actually be very aggressive. So this is a patient that we just warned the parents, if her swelling comes back, if she notices any of that edema, she needs to be seen again for repeat imaging. And then this is going to be our more classic presentation of a patellar bursitis, a 57-year-old white female who tripped on concrete steps and just hit her knee directly. She had immediately swelling and pain, was actually seen in the ER and had x-rays. And they basically gave her an ACE wrap and told her to follow up with orthopedics. She presents to clinic 3 days after the injury with continued pain and swelling in the anterior knee. She had obvious swelling noted in the anterior knee. It's ballotable. You can push the fluid around, but no pain with palpation of the patella. She had a negative patellar apprehension test, a little abrasion noted from where she fell. Her range of motion was a little bit limited just because of the swelling, but she was really pain-free and she was ligamentously stable. So when you look at this video here, I put my probe right smack dab over that patella. She's got this big prepatellar bursitis. You can see the patella here and the long axis view, kind of short axis of the patella, and then the bursa and the long axis view there. So I just kind of, again, I milk that fluid over to show what it looks like. This patient also underwent an ultrasound guided aspiration. You can kind of see on my left picture here, I probably was compressing the probe a little too much, which is making all the fluid go over here immediately. But again, making sure you know where that needle tip is and then doing that full aspiration. Patients don't like to be poked in the kneecap with a needle. So just a pro tip there. So again, I take that fluid and milk it over to the side. And that is the end of my case. So we'll take questions now.
All right, thanks, Emily. Great job. That was very comprehensive and great picture. So thanks for doing that.
Yeah.
I have a couple points, and then like always, Doug will have some very good points to make as well. So, you know, for me, I think our protocols are very similar. You know, there's a ton of crossover between the anterior and medial knee. So I almost always include most structures from both, you know, including, you know, medial joint line, MCL, that sort of thing, like you mentioned. And I think, you know, over the past, I don't know, year and a half, 2 years, I've been doing this, you know, on every single patient, but including that infrapatellar branch saphenous nerve, I think is really important. You know, I see so many patients, you know, young athletes, post arthroscopy, you know, persistent pain or new pain after their scope, repeat MRI is negative. You know, patellar tendon looks okay. This kind of gets chalked up to patellofemoral pain syndrome. But every so often, you know, I'll see either a post-scope or post-traumatic infrapatellar branch saphenous nerve neuroma, or kind of focal pain with sonal palpation along the course of that nerve, you know, presumably a neuritis. And so I think this is something that can often be missed, you know, that nerve causing some of this, you know, somewhat atypical anterior medial knee pain. So I think that's, like you mentioned, that's important to consider that in your protocol here.
And how I approach patients too is I just tell them, like, listen, we can do a block and just see if it helps you. And I'll do just a diagnostic block and have them keep a diary and then see if it helps. Yeah. And then in the future, we can talk about, you know, more intervention if we needed to. But I do a lot of diagnostic blocks on that to see if it helps with patient pains, because I get a lot of patients who have seen their surgeon get frustrated and they just want a second opinion. So it's a pretty easy thing to do. Yeah, no, absolutely. I agree with that. The other point that, just to reiterate, and you made this point a couple of times, and I think it's very important, you know, these bursae around the knee, the fluid within them is often highly compressible, highly compressible, and even minimal transducer pressure can cause you to not see fluid within the bursa. And so, like you mentioned, and what I always tell our fellows is, you know, when you're taking, you know, ultrasound images of these bursae around the knee, I want to see a layer of gel, you know, overlying that region, especially for like the prepatellar bursa, to show and to prove that they are floating the transducer, you know, in an attempt to prevent a false negative scan. So that's, like you mentioned, I think incredibly important. And then the last thing just to mention, you know, for my entire examination for the anteromedial knee, I'll have patients supine, pillow underneath their knee, kind of, you know, flex to, you know, 15 or 30 degrees. If I am going to do somewhat of a more in-depth evaluation of what we can see of the trochlear cartilage, I'll have them flex their knee up to 90. I think that gets a bit of a better image. But yeah, just one point to make there. All right, Doug, do you have anything you want to add?
Yeah, so Emily, really concise, hit all the highlights for complete anterior knee. Why I just mentioned, would you bring up that image you had of the medial patellofemoral ligament? But I just want to make a couple comments. One is, I do a modified anterior knee protocol for every knee exam. So if I'm asked to, you know, image for a Baker cyst or for the common fibular nerve, my knee protocols always start with a modified anterior exam. And that's because, you know, having a knee effusion, for example, impacts all of the knee. And so those are important clues. Another important clue that we don't talk about a lot, but we all see, is thickening of the suprapatellar synovial recess, as well as recesses of the medial and lateral gutters. And that obviously means there's something chronic going on, some chronic sort of synovial thickening. So the most common reason would be osteoarthrosis. So if we see a 45-year-old that, you know, is having knee pain and we see this chronic thickened suprapatellar synovial recess, I mean, that's an important clue. And I know we see that all the time, but it's not talked about a lot. And for me, that's something that I look for and provides an important clue. This view on Emily on the right-hand side, this is a common question we get a lot with the anterior knee exam, and that's about the medial plica. And so what we see is the medial retinaculum, with the bilayer, and that hyperechoic triangle is the alar fold. And then as you know, Emily, but for people on, we really can't see the medial plica unless we have a significant knee effusion, and usually if it's thickened. And so that's a common question I get, at conferences as well. Can we see the medial plica? And so what we're seeing again is the alar fold. We see the medial patellofemoral gutter, but we're not really seeing the plica. But the plica would be a linear, thickened, and often hypoechoic due to shadowing and anisoptropy that would be medial to that alar fold. So I just wanted to make that comment because it's a common question I get. And then finally, for me, there's a superficial and deep infrapatellar bursa. You can have a small amount of normal fluid within the deep infrapatellar bursa, and I see that fairly often. It is a synovial line bursa. And so if you have a small amount of fluid without associated pathology, that's not necessarily pathologic. I have never seen a superficial infrapatellar bursa without problems at the tibial tubercle. So for me, that's always associated with some sort of distal patellar tendon abnormality, whereas a small amount of fluid within the deep infrapatellar bursa can be physiologic. But as Emily demonstrated here, mostly, I see it with patellar tendinosis, whether it's even a proximal patellar tendinosis, more commonly distal. Because it's synovial line, I've seen it in patients with underlying inflammatory arthropathy, and so that could be another cause as well. Emily showed a great case of PVNS. So just a couple points, because the anterior knee exam is a common exam, and so I just thought I would mention those. But again, it was a perfect presentation, concise and great ultrasound images. So thanks, Emily.
Yeah. Oh, yeah, no problem. One thing I would tell my fellows when I'm teaching my fellows, if you have any patients who are working construction or do flooring, they almost always will have usually non-pathologic, but they almost always have a swollen prepatellar bursa or infrapatellar bursa. So great patients that if you're just happening to look at them and have the probe on, just look at that bursa. They probably don't have pathology there, but just because they're on their knees all the time, they get that thickened callus, and almost always you can do that. So that's a great patient if you're just looking for incidental pathology to find it on. So.
Sure. Yep.
All right. So thanks again, Emily. Again, great job. That's exactly the protocol we wanted presented, and exactly what what a lot of us do. So thanks so much for going through that. I think that's super helpful for everybody here. All right, guys. So as usual, off next week. We're back on November 12th. So Dr. Eric Lotzka out in Washington is going to be giving a talk about a paralabral cyst. So again, that is November 12th. Otherwise, happy Friday, happy weekend, and everybody stay safe.
Thank you.
Thanks, Emily.
Have a good day.